It's my pleasure to be presenting here today. My name is Amir Anwar, and I'm working as a lecturer of cardiology at Cardiovascular Medicine Department of Cairo University, Qasr Al Aini Faculty of Medicine. Today we're going to discuss the topic of management of ST segment elevation acute myocardial infarction. At the beginning, let's agree on a definition of acute myocardial infarction. We define myocardial injury as an elevated cardiac troponin value of more than 99 percentile of the upper reference limit. And we say that it's an acute injury when there is a rise and fall of the cardiac troponin. Acute myocardial infarction is defined as acute myocardial injury in a clinical setting of myocardial ischemia. Clinical setting of myocardial ischemia means the presence of symptoms suggestive of ongoing ischemia, like typical anginal pain, or the presence of imaging findings suggestive of an acute event, like doing an echocardiography and showing a new regional motion abnormalities. So this means the clinical setting of myocardial ischemia. In general, we separate acute myocardial infarction into ST segment elevation, myocardial infarction versus non-ST segment elevation, acute coronary syndromes, and this separation is essential because it has some reflections on the management, as in patients with STEMI, the management will be focused around reperfusion therapy, as we will see. According to the fourth universal definition of myocardial infarction, there are some types of myocardial infarctions. The two most common types are type 1 and type 2. Type 1 myocardial infarction is defined as myocardial infarction that is caused by atherosclerotic plaque instability. This means either plaque rupture, plaque erosion, plaque hemorrhage. Plaque instability is followed by intraluminal thrombus that leads to decreased myocardial blood flow, causing acute myocardial infarction. This is type 1 myocardial infarction. Type 2 myocardial infarction is an MI that is consequent to an imbalance between oxygen demand and oxygen supply to the heart. This means that it's not related to atherosclerotic plaque instability, but instead it's related to either sudden increase in the oxygen demand, like when the patient experiences ventricular arrhythmias, or any type of tachyarrhythmias, or the patient suffer from acute blood loss. This causes increased myocardial oxygen demand. Sometimes patients with stable coronary artery disease may present with myocardial infarction that is not related to plaque instability, but is related to increased myocardial oxygen demand. Sometimes there are other causes of decreased myocardial oxygen supply rather than plaque instability. For example, like coronary vasospasm or coronary microvascular dysfunction, like also non-atherosclerotic coronary dissection might cause decrease in the coronary blood flow. So type 2 myocardial infarction is not related to atherosclerotic plaque instability. There are other types of myocardial infarctions, like type 3, which is diagnosed post-mortem, and type 4 that is myocardial infarction related to coronary intervention, and type 4 and type 5, which is a myocardial infarction that is related to coronary artery bypass grafting. In this lecture, we are going to focus on type 1 myocardial infarction, which is caused by atherosclerotic plaque instability. The initial management of STEMI, it's recommended that any patient presents with symptoms suggestive of acute myocardial infarction, that this patient should have an ECG within 10 minutes. And because patients with myocardial infarctions are susceptible to ventricular arrhythmias, once a diagnosis of STEMI has been made, the patient should be connected to a monitor with defibrillator capacity in order to provide DC shock whenever the patient experiences any electrical instability. What about blood sampling and cardiac enzymes? It's recommended to withdraw a blood sample for estimation of cardiac enzymes. However, the collection of blood sampling should not cause a delay in the management of STEMI. There are some ECG criteria upon which we diagnose acute ST segment elevation, acute myocardial infarction. These are the ECG criteria that include at least 2 contiguous leads with ST segment elevation more than 2.5 millimeter in men less than 40 years, and ST segment elevation more than 2 millimeter in men above 40 years. In women, the ECG criteria differ a bit. The ECG criteria for diagnosis of STEMI in women include ST elevation of more than 1.5 millimeter in leads V2 and V3, and or more than 1 millimeter in other leads. These criteria applies only in the absence of left ventricular hypertrophy or left bundle branch block. However, there are some specific scenarios and some specific situations where there are some other criteria to diagnose ST segment elevation myocardial infarction. These include patients with left bundle branch block and patients with paced rhythm. We call it Sgarbosa criteria, and Sgarbosa criteria includes the presence of ST segment elevation of more than 1 millimeter in lead concordant with the QRS complex, or the presence of ST segment elevation more than 5 millimeter discordant with the QRS complex, or the presence of ST segment depression of more than 1 millimeter concordant with the QRS complex. I know this might be a bit complex, but we can understand it together. Normally, in patients with left bundle branch block, there is discordance between the QRS complex and the ST segment and the T wave. This means that normally, when we look at V1 and V2, normally the QRS complex looking downwards and the ST segment is slightly elevated above the baseline. This means these are discordant. The ST segment elevation is discordant from the QRS complex, which is looking downwards. However, when there is an acute ST segment elevation, we expect exaggeration of this pattern. So we expect the ST segment elevation to be discordant in V1 and V2 above 5 millimeter, more than 5 millimeter mercury. Above more than 5 millimeter. So this means exaggeration of the normal pattern of ST segment elevation that is associated with the left bundle branch block. In leads where the QRS complex is normally looking upwards, like V5 and V6, the ST segment is normally in left bundle branch block looking downwards. However, when there is ST segment elevation more than 1 millimeter, this means that this ST elevation is significant because it's concordant with the QRS complex. And it's the same for leads where the QRS complex is looking downwards, which are V1 and V2. The ST segment, when it's depressed below the baseline by 1 millimeter, it's significant. So in left bundle branch block and paced rhythm, these are the criteria upon which we diagnose ST segment elevation acute myocardial infarction. However, it's not a rule that in all patients with left bundle branch block that we should see these criteria. However, in any patient with left bundle branch block and symptoms suggestive of acute myocardial infarction, we have to deal with it as acute ST segment elevation myocardial infarction. In patients with isolated posterior myocardial infarction, it presents with ST segment depression in V2 and V3. And in these patients, we can go for the posterior leads, which are V7 to V9. And in these leads, we might see the ST segment elevation. So this is a pattern of isolated posterior myocardial infarction. There is another pattern when there is diffuse ST segment depression in more than 8 leads associated with ST segment elevation in AVR, and this pattern points to either left main occlusion or multivessel disease, and these patients should be managed urgently as cases of ST segment elevation, acute myocardial infarction. When you have a patient in the ER that is complaining of acute chest pain and you have diagnosed the patient as STEMI, it's recommended at first to see the oxygen saturation. If the patient is hypoxic with an oxygen saturation less than 90, it's recommended to put the patient on oxygen therapy. However, with stable patients with oxygen saturation more than 90%, it's not recommended at all to put these patients on oxygen, as hyperoxia might increase the myocardial injury. Also, it's very important to try to control the symptoms of the patients to relieve his pain. IV opioids are among the most common used medications to relieve the ischemic pain. However, this might be on the expense of decreasing the GIT absorption of antiplatelets medication. So IV opioids should be used cautiously whenever needed and should not be routinely given. When we talk about ST segment elevation, acute myocardial infarction, this means reperfusion therapy. We have ST segment elevation, acute myocardial infarction, meaning that there is one of the epicardial coronaries that has been completely occluded, and this calls for reperfusion therapy. Primary PCI is a preferred option. However, whenever primary PCI is not an immediate option, fibrinolytic therapy can be the alternative and should be initiated as soon as possible. We have to remember that all studies have shown that primary PCI is superior to fibrinolytic therapy in long-term prognosis. However, sometimes primary PCI is not an option and is not immediately available. In these instances, we have to go for fibrinolytic therapy. Let's agree on some definitions that will be used in the coming slides. The first definition is first medical contact. First medical contact means the time point when the patient is either initially assessed by a physician, a paramedic, nurse, or other trained emergency medical service personnel who can obtain and interpret an ECG. So if you have an equipped ambulance with a crew that is able to obtain and interpret ECG, this can be considered the first medical contact. The STEMI diagnosis refers to the time point at which the ECG has been interpreted as ST segment elevation, acute myocardial infarction. Primary PCI means emergent PCI, either with balloon or stent or with any device, performed on the infarct-related artery without fibrinolytic treatment. Rescue PCI means that the patient had received fibrinolytic treatment and it was not successful, and then emergently PCI was performed. So we call it rescue PCI. Routine early PCI strategy after fibrinolysis. This means coronary angiography with PCI to the infarct-related artery that is performed between 2 and 24 hours after successful fibrinolysis. Pharmacoinvasive strategy is a broader term that includes both rescue PCI and routine early PCI after fibrinolysis. So these are the definitions related to the management of STEM. The management of STEM should be focused around time, because the classical teaching says minutes equal muscles. Every minute that passes equal the loss of myocardial muscles. Here the patient might present either to the emergency service or to non-PCI center or to PCI center. This is the first medical contact, and it could be one of these, either the emergency, the non-PCI capable center, or PCI capable center. It's recommended that in all these sites an ECG is obtained, and the diagnosis of STEMI should be done within less than 10 minutes. If the patient presents to non-PCI center or to the emergency department, the time to PCI should be calculated, so should be estimated. How long will it take to deliver the patient to a PCI center, and how long will it take for the center to perform the PCI? This time should be estimated. If the estimated time is less than 120 minutes, so this patient should be transferred to a primary PCI strategy. And if this time is estimated to be more than 120 minutes, so fibrinolysis should be initiated, and it should be initiated in less than 10 minutes. If the patient presents to primary PCI capable center after STEMI diagnosis, it's recommended that primary PCI should be performed in less than 60 minutes. So these are the time intervals that we have to pay attention to. In the first 12 hours after STEMI, primary PCI is recommended as class 1A, while fibrinolysis can also be given whenever primary PCI is not an option, or whenever prime PCI is not available. After the first 12 hours from the onset of acute myocardial infarction, there is no role of fibrinolytic therapy. However, up to 48 hours, primary PCI can be offered to asymptomatic stable patients. After 48 hours, it's not recommended to do routine PCI to patients who present with these patients. We call them missed STEMI. However, if the patient still has ongoing ischemic symptoms, or in case of hemodynamic instability, or in case of electrical instability, primary PCI should be offered regardless the time from the onset of acute myocardial infarction. We have to remember that in some instances, in the absence of ST segment elevation, acute myocardial infarction, primary PCI strategy is indicated in patients with suspected ongoing ischemic symptoms suggestive of myocardial infarction, and at least one of the following criteria: patients presenting with hemodynamic instability or cardiogenic shock, patients with recurrent or ongoing chest pain that is refractory to medical treatment, if the patient is experiencing life-threatening arrhythmias or cardiac arrest, or if the patient is presenting with acute heart failure or acute mechanical complications of myocardial infarction, if the patient has recurrent dynamic ST segment or T-wave changes, particularly with intermittent ST segment elevation, these patients These patients should be managed as if they are having ST elevation, acute myocardial infarction, and should be sent directly for a primary PCI strategy. Let's talk about some of the procedural aspects of primary percutaneous endocoronary interventions. It's recommended to do a primary PCI for the infarct-related artery. It's class 1A recommendation, of course. After primary PCI, if the patient complained of recurrent chest pain, it's recommended to have a new coronary angiography. It's recommended to always put a stent over balloon angioplasty whenever possible for primary PCI, and now it's recommended to use new generation of drug-eluting stents over bare metal stents. Radial access became the standard of primary PCI after many trials that have shown improved outcomes with radial access. However, this should be according to the operator experience. It's not recommended to use thrombus aspiration as a routine in STEP. Sometimes we use devices called thrombus aspiration catheters to aspirate the thrombus from the arteries, but all the trials that have evaluated the role of the thrombus aspiration catheters failed to show any mortality or morbidity benefit of these devices. However, sometimes it's a useful tool in the cath lab during primary PCI, but the routine use of these devices is not recommended. What about other endocrinaries when you do PCI to, for example, left anterior descending artery, and you have another lesion in the right coronary or in the left circumflex? The guidelines recommend for routine revascularization of non-infarct related artery lesions, either in the same index procedure or before hospital discharge. And some peri-procedural and post-procedural recommendations for pharmacological management of these patients. It's recommended to initiate an antiplatelet therapy for these patients. Prasugrel or ticagrelor now are recommended as class 1A, and clopidogrel can be used as an alternative whenever there is a contraindication or whenever these drugs are not available at the time of an PCI. Aspirin is also recommended as soon as possible for all patients diagnosed with ST segment elevation, acute myocardial infarction. Glycoprotein 2B3A inhibitors now only used as bailout if there is evidence of no reflow in the cath lab or if there is an evidence of high thrombotic burden. These are the doses of the antiplatelet medications used in the management of ST segment elevation, acute myocardial infarction. Aspirin should be given in a loading dose of 150 to 300 milligram orally or IV, or can be given IV if oral ingestion is not possible, followed by maintenance dose of 75 to 100 milligram per day. Clopidogrel should be given in a loading dose of 600 milligram orally, followed by maintenance dose of 75 milligram per day. Prasugrel should be given in a loading dose of 60 milligram orally, followed by maintenance dose of 10 milligram per day. However, in patients with body weight less than 60 kilogram, maintenance dose of 5 milligram per day is recommended. We have to remember that prasugrel is contraindicated in patients with previous stroke, and in patients with above 75 years, prasugrel is generally not recommended, but a dose of 5 mg per day should be used if treatment is necessary. Ticagrelor, the loading dose of ticagrelor is 180 mg orally, followed by maintenance dose of 90 mg twice daily. At the time of cath lab, we have to use anticoagulant therapy. We usually used unfractionated heparin with a dose of 70 to 100 international unit per kg IV bolus when glycoprotein 2B 3A inhibitors are not used. However, when we used glycoprotein 2B 3A inhibitors, the dose is reduced to 50 to 70 international unit per kg IV bolus. Enoxaparin can also be used in a dose of 0.5 mg per kg IV bolus, the same as bivalirudin in a dose of 0.7 mg per kg IV bolus, followed by infusion of 1.75 mg per kg per hour for up to 4 hours after the procedure. What about the imaging? And should we do an echocardiography for all the patients presenting with ST segment elevation, acute myocardial infarction? The answer is no. It's not routinely recommended. However, emergency echocardiography is indicated in patients presenting with cardiogenic shock or hemodynamic instability, because these patients might have underlying mechanical complications that might change the plan of management, like sending the patient to an emergent open heart surgery after angiography, or involving the surgeon in the decision. So emergency echocardiography is only required in patients with cardiogenic shock or hemodynamic instability. When the diagnosis is uncertain, emergent echocardiography can be helpful, searching for new regional wall motion abnormalities. However, it's not recommended to do routine echocardiography that may delay the emergency angiography. After primary PCI and during hospital stay, it's recommended to do routine echocardiography to assess the left ventricular and right ventricular function and to detect any early post-myocardial infarction mechanical complication and to exclude left ventricular thrombus. Whenever the echocardiography is suboptimal or inconclusive, an alternative imaging method like cardiac magnetic resonance imaging can be performed. Of course, during hospital stay, if the patient at any time became hemodynamically unstable, it's recommended to perform emergent echocardiography. After discharge, in patients with pre-discharge left ventricular ejection fraction less than 40, it's recommended to do follow-up echocardiography within 6 to 12 weeks after myocardial infarction to re-evaluate the left ventricular ejection fraction as patients who have persistently low ejection fraction after complete revascularization will benefit from an ICD implantation. What about the maintenance antithrombotic strategy after ST segment elevation, acute myocardial infarction? It's recommended that antiplatelet therapy with low dose aspirin will continue lifelong. Dual antiplatelet therapy in form of aspirin plus ticagrelor or prasugrel or clopidogrel, if these two agents are not available. The DAP therapy is recommended for 12 months after PCI unless there are contraindications like excessive risk of bleeding. Another question, should we prescribe proton pump inhibitors for all patients on DAP therapy? The answer is no, it's not routinely recommended. However, in patients who are at high risk of gastrointestinal bleeding, it's recommended to prescribe PPI. These patients include patients who experienced before GI bleeding, or patients who are on triple therapy, or patients who have gastric symptoms. All these patients should be protected from GI bleeding by prescribing PPI in addition to the DAPT therapy. In patients who are at high risk of severe bleeding complications, we can discontinue one of the antiplatelet therapy after 6 months, leaving the patient only on single antiplatelet therapy, that is usually the aspirin. Some patients who present with ST segment elevation, acute myocardial infarction, and have another indication for oral anticoagulation, triple therapy should be considered for 1 to 6 months according to the balance between the estimated risk of recurrent coronary events versus bleeding. For example, if the patient has high bleeding risk, we can prescribe triple therapy for just 1 month, leaving the patient after that on oral anticoagulant and single antiplatelet agent till the end of the first year, and then discontinue the antiplatelet therapy, leaving the patient on oral anticoagulant. However, if the patient has low bleeding risk and high ischemic risk, we can prescribe the triple therapy for 6 months and then discontinue one of the antiplatelet drugs for the first year, leaving the patient thereafter on oral anticoagulant therapy. In patients with left ventricular thrombus, it's recommended that anticoagulation should be administered for up to 6 months, guided by repeated imaging. What about the routine therapies in the acute, subacute, and long-term phases? Beta blockers are recommended for all patients with acute ST segment elevation, myocardial infarction, especially patients with heart failure or left ventricular ejection fraction less than 40%. And routine oral treatment with beta blockers should be considered during hospital stay and continue thereafter in all patients without contraindications. Lipid lowering therapy should be initiated as soon as possible after STEMI, and we should start high intensity statin therapy as early as possible unless contraindicated, and maintain it long term. In these guidelines, the recommended LDL goal was 70 milligram per deciliter. However, in the recent guidelines of dyslipidemia, the recommendations were to lower the LDL target down to 55 milligram per deciliter using high intensity statin therapy, and if this goal was not achieved, using the maximum tolerated dose of statins, other therapies like ezetimibe might be used. ACE and ARBs should be initiated within the first 24 ACE or ARBs should be initiated within the first 24 hours after acute STEMI. In patients with evidence of heart failure, LV systolic dysfunction, diabetes, or anterior infarction, ARBs, preferably valsartan, is an alternative to ACE inhibitors, particularly in those patients who are intolerant to ACE inhibitors. However, it's a class 2A level of evidence A to prescribe ACE inhibitors for all patients in absence of contraindications. Mineralocorticoid receptor antagonists are recommended in patients with left ventricular ejection fraction less than 40%, heart failure, or diabetes, who are already receiving an ACE inhibitor and a beta blocker, provided there is no renal failure or hyperkalemia. I hope I could cover most of the points that are related to the management of ST segment elevation acute myocardial infarction. I hope that this lecture was of benefit for all of you. Thank you so much.